Welcome to today's lecture on diagnosis in endodontics. The topic learning outcomes for the present lecture are to differentiate pulpal and periapical pathology based on symptoms and results of various tests, evaluate the importance of diagnosis in endodontics, and to interpret various tests in diagnosis of pulpal and periapical pathology. So the examination procedure required to make an correct endodontic diagnosis has various steps. The first step is to obtain patient's chief complaint in his or her own words. This chief complaint should record various aspects like how long the patient is having this complaint and what are the various symptoms related to the given chief complaint. If the patient complains of pain, you have to note down all the features like duration of pain, location, onset, and what are the stimuli which gives rise to pain. If there are any relieving factors, is the pain referred, and if the patient is taking any medication for the relief of the pain. The history should also include the medical and dental history, which includes all present or recent treatments which has the patient undergone and various drugs taken for the same purpose. Followed by history taking comes the clinical examination. Clinical examination should note the facial symmetry, examine all the hard tissues, and note if there is any sinus tract present, soft tissue examination, periodontal status, and in hard tissue it should include caries and restorations, both newly placed as well as defective. Once the clinical examination has been done, then we do some special tests mostly related to endodontics, which are called as pulp tests or pulp sensitivity tests, which include cold test, heat test, as well as electric pulp test. Followed by which we do periapical tests such as percussion, palpation, and biting test using a tooth slot. Followed by which, to confirm your tentative diagnosis, you may have to do a radiographic analysis, which includes periapical radiographs, at least two, using a slope technique or buccal object rule, and if required you will do a bite wing radiography, and if required maybe you may have to do even a CBCT. Additional tests for endodontic purpose are transillumination, selective anesthesia, as well as test cavity. So now let us look at the terminology. As I said, each diagnosis or each condition should be described in two terms. The first term describing the pulpal health and the second term describing the periapical health. So let's look at the first term, that is the terminology used for pulpal diagnosis. We describe the pulpal health. Firstly, we should know what is normal pulp. So before we describe what is abnormal, we have to know how does a normal pulp respond. Pulp is symptom free and normally responsive to pulpal test. Although the pulp may not be histologically normal, but a clinically normal pulp results in a mild or transient response to thermal cold testing, which does not last more than 1 or 2 seconds after the stimulus is removed. So whenever you are doing a cold testing or electric pulp testing, if you apply a stimuli, the patient may respond to with a transient pain when you apply the stimuli, which does not last more than 1 or 2 seconds. Once the stimuli is removed, immediately the pulp reverts back to normal and the patient may not experience any more sensation. So this is how a normal pulp responds to a pulp sensitivity test. The first pulpal condition, which is reversible pulpitis. So how is the terminology reversible pulpitis described? It is described as based upon subjective and objective findings indicating that the inflammation should resolve and the pulp return to normal following appropriate management of etiology. The typical causes are exposed dentine leading to dentinal sensitivity, caries, or deep restorations. Discomfort is experienced when the stimulus such as cold or sweet is applied and goes away within couple of seconds following removal of stimulus. So once the stimuli which are causing pain such as exposed dentine, caries, or deep restoration has been treated, then the pulp should start responding as normal pulp. Remember, reversible pulpitis, there are no significant radiographic changes in the periapical region of the suspect tooth, and the pain experience is not spontaneous. Following the management of etiology, that is caries removal plus restoration or covering of the exposed dentine, the tooth requires further evaluation to determine whether the reversible pulpitis has returned to a normal status. The of pulpal inflammation is called as symptomatic irreversible pulpitis. That is, if the reversible pulpitis has not been treated, then the pulp may go irreversibly damaged, leading to irreversible pulpitis. This condition is based on subjective and objective findings that the vital inflamed pulp is incapable of healing, and the only treatment left here is root canal treatment. The characteristics may include sharp pain upon thermal stimulus, which might be a cold test or a heat test, which lingering pain, which is often more than 30 seconds or longer after the stimulus removal. Remember, in previous conditions, normal pulp as well as in reversible pulpitis, we have noted that if we have given any stimuli, the the pain or sensation, as the appropriate word is sensation, the sensation is there only for 1 or 2 seconds until the stimuli is given, and then the pulp immediately goes back to normal and there is no sensation. Whereas in symptomatic irreversible pulpitis, this pain usually lingers for a longer time, not like 1 or 2 or less than 5 seconds. Patient may also complain of spontaneous or unprovoked pain, and the pain refer to other regions based upon the location of the tooth. Sometimes the pain may be accentuated by postural changes such as lying down or bending over, and even over-the-counter analgesics are typically ineffective in this case. The common etiologies may include deep caries very close to the pulp or involving pulp, extensive restorations or fractures exposing the pulpal tissues. Teeth with symptomatic irreversible pulpitis may be very difficult to diagnose because the inflammation has not yet reached the periapical tissues, thus resulting in no pain or discomfort to percussion tests. In such cases, dental history and thermal testing are the primary tools for assessing the pulpal status. Let's move on to next condition, which is asymptomatic irreversible pulpitis. If we break down the terminology, the first is asymptomatic, which states that the patient is not complaining of pain, and even after we give a stimuli, it almost responds to like normal. Okay, almost responds like normal, but the pulpal health is in irreversible, the pulpal inflammation is irreversible. So it is a clinical diagnosis based on subjective and objective findings, which indicates that the vital inflamed pulp is incapable of healing and root canal treatment is indicated. These cases have no clinical symptoms and usually respond normal to thermal testing, but may have trauma or deep caries that would have likely resulted in exposure following removal. So, during the clinical examination and diagnosis, you have taken a restoration, you have taken a radiograph, and you find that the caries is in very close approximation to the pulp or involving the pulp. You do a thermal testing, but the pulp responds normal like a vital pulp, but the caries is very close to the pulp, or while excavation of the caries you fear that there will be a certain exposure of the pulp, or there is a non-carious lesion where it has involved pulp exposure, but on thermal testing it responds normally, then those conditions we diagnose as asymptomatic irreversible pulpitis, and usually the treatment of choice is root canal treatment. Moving on to next condition, which is pulp necrosis. Here the inflammation has progressed to a state where it has caused complete necrosis of dental pulp, indicating the death of dental pulp. The treatment of choice is root canal treatment. Here the pulp is non-responsive to pulp testing and the tooth is asymptomatic. The pulp necrosis by itself does not cause apical periodontitis, leading to symptoms such as pain on percussion, or there is radiographic evidence of osseous breakdown unless the canal is totally infected. Some tooth may mimic as a pulp necrosis, which are like tooth having calcifications, or the patient has a recent history of trauma, or simply the tooth is just not responding. Special emphasis here is a recent history of trauma. In these cases, if you do a pulp testing, it may not respond um, to pulp sensitivity test, so you have to do after 2 months again, after the after the trauma, to and note the response of the pulp. Okay, so moving now, let us look at how to describe the status of the pulp where a root canal treatment is initiated, or the tooth has been root canal treated. So the first is a previously treated. It is a clinical diagnostic category indicating that the tooth has been endodontically treated and the canals are obturated with various filling materials other than intracanal medicaments. So, if a tooth has been root canal treated and obturation has been done and a filling material is not an intracanal medicament, then the pulp is described as previously treated. The tooth typically does not respond to thermal or electric pulp testing. If a root canal treatment or any endodontic treatment has been initiated and done like partially endodontic therapy such as pulpotomy and pulpectomy, and the filling material is not gutta-percha or totally not obturated, and the term used here is previously initiated therapy. So there are two words which are described, two words are used to describe the status of the pulp. If it is completely treated, it is called as previously treated. If it is incomplete or partial therapy has been done like pulpotomy and pulpectomy, the word used is previously initiated therapy. So these are the various terms which are used to describe the status of the pulp. So the first is normal pulp, the second is reversible pulpitis, the third, if the inflammation progresses to a stage where it cannot be reversed, it is called as irreversible pulpitis. In irreversible pulpitis, we have two terms, which is symptomatic irreversible pulpitis and asymptomatic irreversible pulpitis, followed by if the inflammation has led to necrosis or death of the pulp, if the pulp is described as pulp necrosis. Okay, later on to the terms utilized and the terms used to describe the status of the pulp where endodontic treatment has been done, it is called as a previously treated. If the endodontic treatment is usually partial therapy such as pulpotomy and pulpectomy, which has not resulted in complete filling of the root canals, it is been described as previously initiated therapy. Okay. Now let's look at various terms used for periapical diagnosis. So as I said, each tooth should be described in two words for endodontic diagnosis. One is to describe the pulpal health, and the second word to describe the periapical health. So now let's look at the terminology used to describe the periapical health. Okay. First, how to describe a normal apical tissues. A normal apical tissues are not sensitive to percussion and palpation testing, and radiographically, the lamina dura surrounding the root is totally intact and the periodontal ligament space is uniform here. As with pulpal testing, comparative testing for percussion and palpation should always begin with normal tooth as a baseline for the patient. Whereas In symptomatic apical periodontitis, here it represents inflammation usually of the apical periodontium, producing clinical symptoms involving painful response to biting and or percussion or palpation. This may or may not be accompanied by radiographic findings, that is, depending upon the stage of the disease, there may be normal width of the periodontal ligament or may be a periapical radiolucency. Patient usually complains of severe pain to percussion and of palpation, which is highly indicative of degenerative pulp, and the treatment of choice is usually root canal treatment. Term which is asymptomatic apical periodontitis. Again, if you look at the term, it is asymptomatic, that means there is no pain. It is an inflammation and destruction of the apical periodontium that is of pulpal origin. It appears as apical radiolucency and does not present clinical symptoms such as pain on percussion or palpation. So how do we diagnose? When you take a radiograph, if you find that there is a destruction of the apical anatomy, that is, and the lamina dura is not intact or the periodontal ligament space appears widened, then the diagnosis we give as asymptomatic apical periodontitis, and percussion and palpation tests might give normal response in this condition. In chronic apical abscess is described as an inflammatory reaction to pulpal infection and necrosis characterized by a gradual onset. There might be little or no discomfort, and an intermittent discharge of pus through an associated sinus tract is noted. Radiographically, there are typical signs of osseous destruction such as radiolucency around the periapical area. If there is a sinus tract and there is discharge of pus through the sinus tract, to identify the source of draining sinus tract, what you can do and insert a or thread a gatapacha cone. Usually the size of the gatapacha cone preferred is 20 or 25. 25 size is the most preferred gatapacha cone. This gatapacha cone is carefully threaded through the sinus tract through the stroma or opening until it stops, and a radiograph is taken to note from which tooth the pus discharge is happening. The treatment of choice for chronic periapical root canal treatment. The next condition is acute apical abscess. Unlike chronic apical abscess, here the inflammatory reaction to the pulpal, this is again an inflammatory reaction to pulpal infection similar, but the pain is very rapid in onset, pain is spontaneous, there is extreme tenderness of the tooth to pressure, formation of pus, that is swelling is noted. There may be no radiographic signs of destruction, and the patient often experiences systemic conditions such as malaise, fever, as well as lymphadenopathy. So this is the only condition, if you note, where antibiotics might be required because there are systemic symptoms like malaise, fever, and lymphadenopathy. In other conditions, what we do not prescribe antibiotics. In all other pulpal condition as well as in periapical conditions, we do not prescribe antibiotics except for acute apical abscess where antibiotics are required because of presence of systemic symptoms like malaise, fever, and lymphadenopathy. Coming to next periapical condition, which is condensing osteitis. Condensing osteitis is a diffuse radio-opaque lesion which represents a localized bony reaction to low-grade inflammatory stimulus, usually seen at the apex of the tooth. Before we move on to clinical examples, I will go through the various pulpal as well as periapical terms which are used to describe the status of the tooth. So for pulpal, first term is a normal pulp. Then if the inflammation may progress to reversible pulpitis, then it may progress if it is the tooth has not been treated, the inflammation may progress to irreversible stage where the pulp can be described as a symptomatic irreversible pulpitis or symptomatic reversible pulpitis based upon presence or absence of pain. If this is not treated, it may cause death of the pulp. Then we describe it as pulp necrosis. Okay, If you note that there is some endodontic treatment has been done, if it is partially treated, it is called as previously initiated. If complete root canal treatment has been done, then we describe the pulpal condition as previously treated. Okay, then moving on to periapical. In periapical, first is a normal periapical tissues, followed by symptomatic periapical tissues if there is pain on percussion or palpation. Then if there is no pain on percussion and palpation, but on radiograph there is evidence of widening of the periodontal ligament space, or if the lamina dura is not intact, then we describe the condition as asymptomatic apical periodontitis. Then if you find there is a sinus tract associated with the tooth, and in a radiograph there is complete destruction at the periapical area, then you describe the condition as a chronic apical abscess. If there is a presence of swelling as well as with severe pain, the tooth is slightly moved out of the socket, and severe pain to percussion palpation, then you describe the condition as acute apical abscess. Whereas in a radiograph, if you note that there is deposition of the bone around the periapical area, and the tooth is negative to pulpal sensitivity test, then the condition is described as condensing osteitis. So with this background, we try to we move on to the clinical examples. Okay, we discuss various clinical examples and come out with a diagnosis. Example here. So looking at this radiograph, if we see there is a maxillary left first molar which has got occlusal mesial caries, and the patient has been complaining of sensitivity to sweets and to cold liquids. There is no discomfort to biting or percussion. The tooth is hyper responsive to endo eyes with no lingering pain. So let's try to break down from the beginning. So there is caries which involves the enamel and dentine. The caries is on the occlusal mesial surface, and the patient complains on sensitivity to sweets and cold liquids. Okay, so first we try to describe the pulpal, and then we go to the periapical status. So um, sensitivity to cold as well as sweets, and the tooth is hyper responsive to endo eyes with no lingering pain. So tooth is responsive to the cold stimulus, but there is no lingering pain. So the term which you have to give attention is no lingering pain. If there is no lingering pain, then it is not a irreversible pulpitis, so it might be mostly reversible pulpitis. So the term here, if you give importance to this statement which describes no discomfort to biting or percussion, then the it might be normal apical tissues. Even in the radiograph there is no widening of the periodontal ligament space, and there is no destruction of the apical bone here. So let's look. So the diagnosis here is reversible pulpitis and normal apical tissues. So what is the treatment? Treatment would be excavation of the caries followed by placement of permanent restoration. But while doing the caries removal, if the pulp gets exposed, the treatment would be non-surgical endodontic treatment followed by permanent restoration such as crown. So moving on to the next example. Okay, if you look in at here, there is an IOPA. IOPA of a premolar, first molar and second molar. So let's look at the mandibular right first molar. The tooth here is hyper responsive to cold and sweets over the past few months, but the symptoms have now subsided. Now there is no response to thermal testing. So if there is no response to thermal testing, whereas previously it was hyper responsive, there is no tenderness to biting and pain to percussion. Radiographically, there is a diffuse radio opacities. So diffuse radio opacities around the roots, around the root apices. Okay. So let's look at the answer. The answer here is pulp necrosis, because previously there was pain without any treatment. Now it is totally become non-responsive to thermal testing or electric pulp test. So the condition is described as pulp necrosis. Tooth is a tender to percussion, so it is symptomatic apical periodontitis, and there is evidence of bone formation around the apical area, so it is a condensing osteitis. Treatment would be non-surgical endodontic treatment followed by build-up and crown. Over the time, once the treatment has been done, the condensing osteitis should regress partially or totally. Third example, IOP of the maxillary area. So here you can see a premolar, molar as well as first molar as well as second molar. So we are looking at the second molar. So following the placement of full gold crown on maxillary right second molar, the patient complains of sensitivity to both hot and cold liquids. Now the discomfort is spontaneous. So if I look at the statement, initially there was sensitivity to hot and cold liquids, but now the discomfort is spontaneous. If the discomfort becomes spontaneous, usually it is irreversible pulpitis. So upon application of endo eyes on this tooth, the patient experiences pain, and upon removal of stimulus, the discomfort lingers for 12 seconds. Remember, in normal pulp as well as in reversible pulpitis, once the stimuli has been removed, there will be no pain. But if the pain lingers, then the condition is irreversible pulpitis. Response to both percussion and palpation are normal. Radiographically, there was no evidence of osseous tissue. So there is radiographically no evidence of osseous tissue breakdown, and the periodontal ligament space here looks normal. There is no break in lamina dura, so we can describe it as a normal apical tissue. So let's here, as I said, diagnosis symptomatic irreversible pulpitis, because even after the removal of the stimuli, the pain lingers, and the periapical status is of normal apical tissue. The treatment here is non-surgical endodontic treatment followed by repair of the permanent restoration. Next example, here is a mandibular right lateral incisor which has an apical radiolucency that was discovered during routine examination. There was a history of trauma more than 10 years ago, and the tooth was slightly discolored. The tooth did not respond to endo eyes. Okay, the tooth may not respond to endo eyes means the tooth is necrosed. But remember, the duration of trauma is the most important. If it was a recent trauma and you do a pulp sensitivity test, it may give a negative response, as I said. So you have to wait till 2 months before you come to the conclusion that it is necrosed, at least 8 weeks. Okay, so but here the duration of the trauma was 10 years ago, and there is no response to the pulp sensitivity test, so we can diagnose it as pulp necrosis. Okay, tooth was not tender to percussion or palpation, but if you look at the radiograph, there is a definite radiolucency here with destruction of osseous destruction, evidence of osseous destruction. So the pulpal would be of pulp necrosis because no response to pulse sensitivity test, whereas a periapical term is asymptomatic apical periodontitis. Okay, the treatment of choice here is non-surgical endodontic treatment followed by bleaching because the tooth is discolored, and a permanent restoration. Coming to next clinical example, if we look here to mandibular left first molar, which demonstrates a relatively large apical radiolucency, which includes the mesial and distal roots along with the furcation involvement. Okay, periodontal probing depths were all within normal limits. The tooth did not respond to cold testing, and both percussion and palpation tests elicited normal response. There was a draining sinus tract. Okay, so whenever there is a draining sinus tract, what you do is they take a gatapacha stake, gatapacha cone, which is usually of 25 size, and slowly thread into the opening until it completely goes and stops. okay, and expose a radiograph. So here if you see the Gatapacha cone which has been inserted is going towards the um, distal root, okay, distal root of the molar, okay. So and there is also in the radiograph there is evidence of recurrent caries around the distal margin of the crown. So coming to the diagnosis, since there was no response to sensitivity test, we diagnose it as pulp necrosis. As there is a draining sinus, remember, if there is a draining sinus you would diagnose it as chronic apical abscess, okay. If there was no draining sinus, then I would have diagnosed it as asymptomatic apical periodontitis, but if there is a draining sinus, then the diagnosis is usually chronic apical abscess. The treatment of choice: first remove the crown, because there is a current caries around the margins of the crown, so which has to be restored and a new crown has to be done, okay. Non-surgical endodontic treatment has to be done because the tooth is necrosed, and then followed by placement of a new crown. So the next example, okay, I don't have a radiograph here, but I'll just read out the um, case description. Maxillary left first molar which was endodontically treated. Remember, it has been endodontically treated more than 10 years ago, okay. So the pulpal condition would be of previously initiated or previously treated. Let's look at the complete description. Patient now is complaining of pain on biting over the past 3 months. So there is pain on biting, so there is inflammation at the periapical area, which this statement says that there appears to be apical radiolucencies around all the three roads, okay. Inflammation is there, pain on biting is there, and there is evidence of apical radiolucencies. The tooth was tender to both percussion as well as to tooth slot. So now let's look at the answer based upon this. The tooth is previously treated as well as a symptomatic apical periodontitis, because there is pain on biting, so the diagnosis is asymptomatic apical periodontitis. If there was a description as there is no pain on biting, then we describe the periapical condition as asymptomatic apical periodontitis. The treatment here would be non-surgical endodontic treatment followed by permanent restoration of the access cavity. Coming to next example, let's look at the maxillary left lateral incisor. If you see the radiograph carefully, there is a radiolucency involving the enamel and dentine on the mesial side. The radiolucency here is very close to the pulp, okay, whereas in the apical region there is a diffuse radiolucency around the periapical area. There is no history of pain as well as tooth is asymptomatic. There is no response to endo eyes. If you look at these statements, we can come to a conclusion that there is no response to electric pulp test as well as there is no pain to the tooth. So the pulpal condition might be mostly pulp necrosis, okay, pulp necrosis. There is no tenderness to percussion and palpation. Okay. So based upon the history, the pulpal condition can be described as pulp necrosis because there is no history of pain, as well as the pulp sensitivity test, there is no pain. And the periapical condition can be described as asymptomatic apical periodontitis because there is no pain on biting, as well as percussion test there is no pain, but there is evidence of apical radiolucency. The treatment here is non-surgical endodontic treatment followed by placement of permanent restoration. So if you look at all these clinical examples, we have used two terms to describe the condition. One is the term to describe the pulpal health, and the term to describe the periapical health, okay. So this is about the diagnosis in endodontics. If you have any doubts regarding this one, please reach out to me using your discussion on e-portal or can meet personally. Thank you very much.